Hi, my name is Laura Jones, and I will be addressing sexual health and oncology of chronically ill patient populations, as well as how to utilize sensate therapy when working with patients. A little bit about me. I graduated from Kent School, and I did specialize in psychosocial oncology. I've spent my entire career in the field of oncology. I was a social worker in our neuro-oncology, blood and marrow transplant, or BMT clinics, as well as our gynecologic oncology clinic. I became a manager of our patient service line in 2020 and have been in that role since that time. I did complete the University of Michigan Sex Therapy Certificate Program in 2020. About 20% of my current workload is doing sex therapy with patients and couples through our BCC resource centers at Brown Cancer Center. I am also a therapist at Gilda's Club, and I currently do our prostate networking groups and our breast cancer support groups. I also worked for Memorial Sloan Kettering Cancer Center as a contract therapist in 2 studies working with older adults adjusting to a cancer diagnosis, as well as young adults from ages 18 to 40 who've also been recently diagnosed. Today, I'll be talking about why sexual health is important in the fields of oncology, but this can be applied to many patient populations, particularly those in chronically ill situations. I'll be talking about how to understand what sexuality means in oncology, as well as differentiating that between sexual function. We'll be talking about how to conduct a sexual health assessment. And then finally, I will be talking about how to utilize sensate-focused therapy with patients. And we'll do a case study. I know that this is pre-recorded, but I've included my email and contact information in the last slide. So if you have any questions from today, feel free to email me directly. So initially at Brown Cancer Center, we thought that we were not addressing patients' sexual health needs in an appropriate manner. A few years ago, we conducted a mixed methods quality survey to assess the need for sexual health interventions in all of our medical oncology clinics, as well as our radiation oncology and bone marrow transplant clinics. Participants were asked if any medical professional, not just social workers, had inquired about their sexual health at any point in their treatment. They were asked to rate their perception of how well their sexual health needs were met on a Likert scale of 1 to 5. And then they were encouraged to provide additional information regarding their experiences. Some exclusion criteria included that patients must have a cancer diagnosis that was originally diagnosed or recurred in the last 5 years, and that participants must have received the majority of their treatment at Brown Cancer Center. Many patients are diagnosed at other centers and come to the Cancer Center for second opinions. These patients were not included on the survey. Finally, patients must have been in treatment for at least 1 month at Brown Cancer Center prior to participating in the survey. Treatment included chemotherapy, radiation, and or medical oncology appointments. Patients who just received surgery were excluded from participation, and this is because many patients who just received surgery were not included in our multidisciplinary clinics and may have had reduced access to providers, including social workers. The study was conducted between March and July of 2018. A total of 70 patients were surveyed with an average age of about 55. Had a good gender split of about 33 women and 37 men. 36 individuals were married, 20 were single, 9 were partnered, 3 divorced, 1 was widowed, and 1 did not respond. 80% of patients surveyed reported that no one had addressed sexual health issues with them at any point during treatment. This was not surprising to us at the time, but certainly reflected the need for additional intervention in the oncology setting. The average perception of how well sexual health needs were met were about a 1.9 out of 5. I think the reason that this was even higher than, a 1 or less out of 5 was many patients were not expecting their sexual health needs to be addressed, or would say things like, I'm widowed or I'm single. Why would anyone bring this up with me? We'll talk a little bit more about that. This is a breakdown of the patients surveyed and the clinic types. So we see here, for instance, our head and neck patients, they reported that their needs were not addressed at all. And then several of the patients in our BMT and breast clinics tended to have more intervention regarding sexual health and sexual health needs. These are some comments from patients about their experiences in the clinic setting. And the reason that I'm focusing on these comments today is to provide some insight into patient perceptions of why are providers not bringing this up. So surveys have shown that about 70% of patients are expecting their physicians or providers to bring up sexual health concerns with them, and about 70% of physicians or providers are waiting for patients to bring it up. So there's kind of a standoff with patient and provider to who's going to bring up this uncomfortable topic. One patient, 23, reported, it would have been helpful if sexual health issues were discussed early on, so I could have been more proactive in researching. I wanted to know about early menopause. It felt like my doctor wanted to wait and see if it happened first and then deal with it. Another patient reported, well, I'm not having sex anyway, so why would anyone bring it up? Why would anyone discuss that at my age? A melanoma patient, 75, reported, it would have been helpful to have someone talk about sexual health problems as a new patient. I had to initiate the conversation about when it was safe to have sex again. BMT patients. So we see, there's a lot of discrepancy in patients feeling like their sexual health needs are not met or undermet. And again, this was limited to oncology patients, but these findings are indicative of a bigger problem within healthcare and other arenas where patients are not asked about sexual health because both patient and providers can be uncomfortable with this topic. Again, these findings demonstrated a significant deficit in the inclusion of sexual health in our conversations surrounding treatment and survivorship. And many patients demonstrate a lack of understanding regarding their sexual health needs and, asking, why would my sexual health need to be addressed when I'm not having regular intercourse? Kim Williams has also attended the Michigan program and was intervening with sexual health towards the end of this survey. So we did note that more breast patients reported actually, having their sexual health needs addressed and having appropriate interventions. Some study limitations. This is also very important to recognize that, this was a very limited study and it was a qualitative survey for patients just within the Brown Cancer Center. So again, we had a limited study sample, and also patients demonstrated a reluctance to discuss these topics in the clinic setting. So our social workers were conducting these interviews within the clinic, and oftentimes patients would not be comfortable, or if they were there with a caregiver that was not a partner or that was a partner, maybe a bit more uncomfortable to discuss. So when we're looking at the bigger topic of sexual health, what is sexual health? So the World Health Organization defines sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. There's also a description of the important component of health and personality throughout the lifespan. All individuals who have experienced chronic illness need to express sexuality in alternative ways in order to maintain and enhance their quality of life. And basically what this is saying is many chronic illnesses have a direct impact on sexual functioning. And this can be directly physical, this can be emotional. Oftentimes, it's a combination of many factors. So it's important for patients to be able to find ways to express themselves sexually while going through treatment or while dealing with a chronic illness, and for us as providers and social workers and therapists to normalize this. When talking about sexual function, it's important as social workers, as therapists, to help patients differentiate identity. Basically, an example of this would be I am a cancer patient versus I am a sexual being with cancer. Recovery of sexual health and sexuality in the context of cancer or other chronic illnesses does not imply a return to baseline. And basically what this means is that patients who undergo cancer treatment or dealing with other chronic or debilitating illnesses, may not achieve the sexual function that they had before diagnosis. This is not always a bad thing, but there is certainly grief and loss surrounding this. And it's important for patients to know that recovery or in order for them to achieve sexual function does not mean that they're going to have the same sexual function that they did before their diagnosis. So interventions need to include education around what can patients expect, what is normal in the context of what treatment that they're receiving, what are the side effects, and what are their options in terms of treatment. This can be both pharmacologic and non-pharmacologic. And then finally, if patients have a more complex concern, history of trauma, body image concerns, relationship satisfaction, counseling can be appropriate. And looking at the sexual response cycle, the most traditional response cycle looks like arousal, plateau, and orgasm. However, in order to achieve this, you will need to have an intact vascular and sensory or parasympathetic nervous system. And we know that cancer and other chronic illnesses can greatly impact this. For instance, individuals who receive radiation to their pelvic floor, individuals who have neuropathy, for those who undergo a stem cell transplant or other solid organ transplant, they may be dealing with graft versus host disease, which also can affect the genitals. Surgery can greatly affect the nervous system. For instance, individuals who receive radical prostatectomy may have nerves severed during the surgery that are required to achieve an erection. So it's important to realize that there are direct physiological effects that can prevent someone from achieving orgasm in the way that they had before. It's also important to differentiate desire versus arousal. So what is desire? Desire is the emotional and psychological wanting of sexual relationship with a partner. And that does not mean necessarily sexual intercourse, but that means that that's an emotional pull that someone has to be sexually attracted to whoever their partner is or whoever they may want to be having sex with. Arousal is directly related to the physiological response of the body to sexual stimuli. And looking more at desire, it's also important to differentiate between spontaneous versus responsive desire. So spontaneous desire basically describes being able to have that attraction or have that desire to have sex with somebody without other stimuli. Responsive desire may look like, a partner offering a bid for a sexual relationship with them, or when someone starts foreplay, starts kissing, hugging, that's when they become more aroused. And there is not a good and bad way to describe this. However, many patients who have a significant change in libido or many patients who have a lot of physiological changes to their ability to achieve orgasm or participate in this traditional response cycle may not be able to have that spontaneous desire or don't experience that spontaneous desire. And there is certainly a sense of loss and grief that goes along with that. This is a visual representation of the traditional Masters and Johnson sexual response cycle. So as you see, there is a direct correlation to excitement, plateau, orgasm, resolution, and arousal. However, as I mentioned before, this is not the case for many patients who experience physiological changes related to medical conditions, cancer, or other chronic illness. I think a more accurate model of desire and arousal for patients who have experienced any kind of medical condition, cancer, chronic illness, or otherwise, is Dr. Rosemary Bassan's model of arousal. Basically, she shows that arousal is more circular and there are more components to it. As you see, arousal can come before or after desire, and that there's a lot of psychological and other factors that directly impact arousal and that plateau. For instance, pain, fatigue, that decreased vascular sensory ability can obviously directly affect arousal. For individuals who've had significant changes to their body, that can include rapid weight loss or rapid weight gain, surgery that affects the appearance of body parts, that's obviously going to affect the way that someone feels about themselves and potentially their partner, or anticipating the way their partner or potential partners can look at them. So this provides a more, I think, accurate model of what sexual arousal and desire look like for individuals who have experienced chronic illness, cancer, or otherwise. So I'm going to be talking about some sexual health tools that you can use basically to assess individuals in a clinic setting for sexual dysfunction. The first is the DUPE model, and this stands for Describe, Onset, Understanding, Past, and Expectations. An example of this would be an individual who is not able to achieve an erection when desired. However, he does experience nocturnal erections. Looking at the onset of the problem, this may have been going on for at least 5 years, but may have had some issues before 5 years ago. Looking at understanding, what is the patient's understanding of why they're experiencing this dysfunction? For this individual, they were thinking this was more so related to the aging process, but also a history of prostatectomy, which can obviously affect the ability for someone to achieve an erection. Past, and this is going to be past interventions that someone has utilized to address the problem. So this person had utilized PDE5 inhibitors such as Viagra, Cialis, vacuum constriction device, prostate massage. They had been to a urologist and their primary care provider. They had tried testosterone and also penile injections. And then expectations. So it's important to assess an individual's expectations for therapy or other interventions to address the sexual dysfunction. For instance, this individual is willing but skeptical to participate in talk therapy to address erection difficulties. Another model for intervention when working with patients in relation to sexual health and sexual health functioning is the PLICIT model. And this stands for permission, limited information, specific suggestions, and then intensive therapy. The permission stands for giving patients permission to raise sexual issues. And this could look like just bringing up sex. As we saw before, many providers are at this standstill with patients and do not bring up sexual concerns or potential sexual side effects with patients because it can be uncomfortable. So oftentimes, by just bringing up or just asking a patient, how are you doing sexually? Have you had any side effects? That provides permission for the patient to talk about their concerns. Limited information. So giving patients limited information about sexual side effects of treatment. This is to not overwhelm the patient, but important to give patients concise information about what they can expect as a result of treatment. This can be done in conjunction with providers or a pharmacist, for instance. I know I work with many pharmacists here and also our oncology team to learn more about what is this treatment? What are some potential side effects of this treatment? What can patients expect? What do most patients experience in terms of changes in sexual functioning? Specific suggestions. So making specific suggestions based on a full evaluation of presenting problems. So if we're going to bring up sexual concerns, it's important to have some offers of suggestions for patients to utilize at home. The more specific, the better. Patients, need to have tangible things that they can do at home, or tangible referrals, for instance, to pelvic floor physical therapy or otherwise that they can utilize. And then finally, intensive therapy. So again, if the patient has very complex sexual health needs, including, any past history of trauma, relationship satisfaction concerns, body image concerns, then a referral to more intensive therapy, which can include sexual health therapy or other psychological support, is appropriate. All right, so I'm going to be talking about how to use Sensate Focus in clinical practice. So what is Sensate Focus? So Sensate Focus was originated by Masters and Johnson and is a hierarchy of structured touching and discovery suggestions. So what does that mean? I'll get into that in a little bit. Basically, Sensate Focus was created to reduce or manage anxiety surrounding sexual interaction. It's also helpful at identifying and addressing dissociation. So for many individuals, especially those who have any history of trauma, and this can also include physical trauma as a result of cancer or other chronic illnesses, may dissociate during sex. And oftentimes, individuals don't realize that they're doing this. And so Sensate Focus is a way to bring in mindfulness into sexual touching and pleasure. Learning how to address pressure. And basically this means, if you have one partner who is constantly pressuring the other partner for sex, and this has created dissatisfaction in the relationship, this can be a great tool to remove that pressure, or learning how to address pressure for both the patient and their partner. Again, talking about that mindful connection to both the self and partner, and these interventions can be done soloed or with a partner, and that's important too. And then also to accumulate sexual tension. So Sensate Focus helps to build that desire. It helps to address libido issues for patients or couples who have struggled with that desire element. So I do want to preface this by saying that before Sensate Focus should be utilized, the therapist or social worker should be conducting a full sexual health assessment. And basically, this means that the therapist is aware of any history of sexual trauma, physical trauma, otherwise. They have a strong understanding of the patient and the patient's sexual history, but also psychological history. They understand the patient's current relationship with their partner, if they have one, and basically, what that would look like for the patient to utilize this. And as we know, the most important aspect of the therapeutic relationship is the relationship with the therapist and the patient. So we want to make sure that that therapist has the trust of the patient before utilizing something like Sensate Focus into treatment. When I use this with couples or individuals, I usually do not do this until I've been working with them for at least several months. Now, before you address the sexual intervention of Sensate Focus, I do think it's important to have both parties present if the patient is partnered, meaning if a patient has a spouse or partner, I want to have them both in session with me before I introduce this exercise. So looking at those stages, before patients start, I have them work on creating a nest. And what is that nest? This is a safe space for individuals to engage in this exercise. It's important that individuals have about 30 minutes to an hour of privacy. And it's important that they find this time when they're not tired. And as always, kind of going back to that Pleasant model, it's very important to get very specific with suggestions, meaning that I have patients and their partners tell me exactly when are you going to carve out time for this? When is a time that you're not tired, not 11 p.m. at night when the kids have gone to bed and you're exhausted. Tell me a specific date and time that you think that this can be achieved. And it's important for people to have clothing off. However, when we're working with individuals who've had significant changes to body, have had physical trauma or other trauma, they may be more comfortable with having some clothing on. So whatever they're comfortable with is the most important. The clothing off aspect is to increase that sensory touch and feel, but the most important thing is that they develop that comfort with being vulnerable with their partner. We want to limit alcohol or substance use before engaging in this exercise. The room needs to be a comfortable temperature. Some lighting on is good to see what you're doing. And then I limit verbal communication. So if a couple is starting off, and this is the first time that they're doing the exercise, I have them say talking is totally off limits. And I'll get into some reasoning for that later. And then also to minimize distractions. So we're always reachable nowadays with our phones, and even if we don't have our phones on us, many people wear Apple Watches or other devices where they could be contacted. And so I have, both individuals limit the use of their phones, electronics, anything that could be a distraction, or keep them from staying focused in the session with their partner. So how do you explain these phases to your clients or patients? So first, I let people know that the optimal desire window, or that period that it's best to increase that spontaneous or responsive desire, is every 48 to 72 hours. So I try to have patients schedule these Sensate Focus sessions at least every 2 to 3 days. And again, kind of getting that specific granular level, I have them do this and tell me specifically when they think that this can happen, when they can fit that into their schedule, because that is going to make it more likely to occur. Before we get started, before I explain, what these phases are, I tell patients that sex is totally off the table. So in doing this, we remove the pressure that comes with touching and with sexual touch for a lot of people. So the phase 1 of Sensate Focus is gradual touching of your partner in turns, with the breast, chest, and genitals off limits. And I also include erogenous zones in this because some people are not aroused by having their breasts or chest touched. So say someone really enjoys, their earlobes, I'll have those off limits as well. And basically in this phase 1, I have each partner spend about 15 to 20 minutes just touching their partner. I tell people you don't have to have a timer on, to kind of count down that 15 or 20 minutes. Just be curious with that touch. I've had people use like feathers or other, instruments to kind of play around with level of touch and sensation, and just kind of be curious with your partner of how it feels to touch them in ways that you may not have before. And I love Linda Wiener's book, Sensate Focus and Sex Therapy, the illustrated manual, because she has very good description of what Sensate Focus can look like. And she's got a lot of really beautiful charcoal images that I'll show throughout this presentation too, that depict a very diverse couples and different ability levels. So once the first partner has taken about 15 or 20 minutes to touch the partner, then they will take turns and the other partner will touch. And at no point in this phase 1 is the couple touching each other at the same time. And again, this can just be about 15 to 20 minutes, but we want to make sure that there's about an equal amount of time spent for touching for both partners. For phase 2, The breast, chest, and genitals and other erogenous zones are on limits, meaning that this touch can include massaging of the breast, massaging of the genitals. However, this is not to bring the person, this is not meant to be masturbatory for the individual. Orgasm can happen, and both parties are meant to just kind of notice that and move on. That phase 3 includes the mutual touching with breast, chest, and genitals off limits. Basically, this means during the dedicated sensate sessions, that touching can occur at the same time, so both parties are touching each other. But again, that breast, chest, and genitals are off limits. Phase 4 includes that mutual touching with these erogenous zones, breast, genitals on limits. And then phase 5 can look very different depending on the couple that you're working with and what their goals are. So I have many couples that I work with whose goal is not penetrative sex. And so we work together to figure out what are the phases, where do we want to kind of stop, or what's comfortable for them. This is the traditional Masters and Johnson's model that I'm talking about today. So again, this is going to be a very, heteronormative, and it's coming from a place of working with a male and a female identified couple. And so this can be modified in many ways to address many different couples. So in that phase 5, the goal is genital contact. And this can look like a stride without insertion of the penis, a stride with insertion, or a stride, let's just say, with insertion and movements. So again, very heteronormative perspective where this is coming from, but couples are encouraged to include any kind of vibrators or other toys in this phase, and get kind of creative with it. Now, this would be the first phase where sex is back on the table, but I really do try to limit that for couples to include just in these phases. And it can take many months in between each of these phases, because what we want is for couples to feel comfortable with each other, to have that pressure totally taken off the table, so that they feel free and comfortable to explore their partner's bodies, with the goal of finding new erogenous zones, finding things that work for them sexually and physically, and also just to build that trust with their new bodies, with their partner's bodies. Oftentimes I find that couples, especially those who've been in relationships with each other for a long period of time, have a menu of things they do sexually. And so when that menu is disrupted by either something like a cancer diagnosis, pain with a certain, position, or change the body part, whether someone's had a mastectomy or someone's had significant surgery to change their functioning, then that's a huge disruptor to, okay, what do we do now sexually? So basically what Sensate Focus does is provide this gradual, again, kind of hierarchy of touching, so that couples have a dedicated and safe space to relearn each other's bodies and relearn, what feels good. And I think this is a great exercise to use really at any time for people who may not necessarily have a history of physical trauma, whether that be medical or otherwise. It's a great exercise for people to have a chance to focus on each other and relearn, what do their bodies look like, what feels good, because changes happen with age and just with time. And it's good to kind of have this dedicated, pressure-free space where people can kind of explore that. So again, here's some modifications for Sensate Focus for couples that may not fit that heteronormative model that we talked about before, or have other, concerns, pain-wise or other. So again, that insertion or penetration is only an option if if it's in the couple's sexual repertoire, capacity, or interest. Meaning, a lot of couples may not have the desire to have penetrative sex, and that is totally okay. Or one of the partners may not be able to achieve an erection, and we can get kind of creative with what does that look like from a sensate focus perspective. And then genital to genital contact may be in any position that's comfortable rather than astride. So for many patients, that may not be a comfortable position for them. So whatever works, laying down, kind of spooning, we can get very creative with this. And again, I very much recommend Linda Wiener's book on how sensate focus works, because she has a lot of illustrations on some modifications and some body positioning that works for individuals with maybe very different body mass sizes or different abilities. Handwriting. Now, this is a great tool to use, especially if someone has a history of dissociating during sex, or if they are not comfortable with their partner touching them, without any control. So I oftentimes see this with individuals who have a history of sexual trauma, that they really enjoy this modification, and I find it beneficial. So handwriting is basically when your partner is touching you, you're able to put your hand on top of theirs and move it in a way that feels good for you. Now, it's important when describing this to both parties that this is a non-judgmental movement of the hand, and viewing it more as, this is something, I'm moving your hand to a place that I like, or I'm moving your hand to change the pressure in a manner that I like, and less so, I don't want you doing this, or I don't want you touching me there. So the handwriting can be a great tool, again, for the person who is receiving the touch to have more control into how they are perceiving touch, or how their partner is touching them. Looking at individuals that have a history of sexual trauma or medical trauma, and unfortunately I see a lot of patients that have both. So I think it's important for the trauma partner to be in full control of the physical contact and pacing, meaning that we can utilize that handwriting modification. That the partner who's experienced the trauma may want to go first and show their partner, what they expect in terms of touch, and I'll have them go first, at every sensate focus interaction. And then also, I tell them that it's important they don't just get through these exercises, because oftentimes we'll see that with couples where, if someone has experienced sexual trauma or other physical medical trauma, during sex, they'll try to just get through it. And this creates a space where a partner feels like they don't have control, they don't have agency to say yes or no during a sexual interaction, and their partner may be completely unaware. But this helps also to manage that dissociation that we were talking about earlier. And some ways to do this is, again, if they're feeling like they're slipping into that, let's just get through this, let's just power through it, it's okay to stop this and let your partner know, hey, this is not a great time for me to be doing this exercise. Can we do something else, maybe revisit this in the future? By utilizing that handwriting, so moving their partner's hand and having control over where and how they're touching them, and then doing some breath work to kind of help them maintain grounding focus during those exercises. So as I mentioned before, sensate focus is not just a tool that can only be used with couples. I also recommend that individuals use sensate focus, with just their own bodies to kind of reconnect with their changing bodies, and to restore that kind of mind-body connection. So this is a great somatic exercise to, again, increase that body awareness through touch. I think that it's so important, especially for individuals who've experienced any kind of medical or physical trauma, to have a somatic intervention to help deal with that trauma. And this can be a great way to bring sexuality back into it, especially if that's a concern for patients. So when I have individuals do this without a partner, I'll have them move through the same series of touch, except that they're just touching themselves. That first phase, again, would look very similar. We're just touching their body in different ways. The chest and genitals can be off limits. That phase 2, they can bring chest and genitals back into the picture. And then, again, of course, some of those phases are shortened or are not appropriate when individuals are doing this by themselves. They can, incorporate masturbation or other toys into those final phases once they feel that connection and comfortability with their new bodies. I have them really focus on the sensations, so warmth, coolness, tingling, the way the touch feels. You have a lot of people who have had really radical surgeries related to their cancer diagnosis. We see here that someone's had a single mastectomy. And so sensation can feel very different. I have a lot of people who, no longer have sensation in their axilla area or their chest area, or they may have some pain with some scar tissue. And so just kind of having some awareness of what feels good, what feels, different than before, what is, sexual to them, what feels, like an erogenous zone it may have not been before. Many individuals receive a lot of sexual pleasure from having their nipples or breasts touched. And when someone experiences a radical surgery like a mastectomy, that can be a huge loss. And so again, it's working through that grief and loss and incorporating those skills while doing, the sensate focus exercises. And really, I have individuals focus on how does touching your body feel and how has that changed since your cancer or other chronic illness diagnosis. So in looking at a case study, I'm going to talk about a patient that I've worked with named Curie. She is a 45-year-old white woman with stage 3 breast cancer. She's had a double mastectomy and reconstruction, and she's completed chemotherapy and radiation. She's currently on hormonal therapy. And basically what all of that means is that she has completed, again, radiation, chemo. She's had this reconstruction and she's on hormonal therapy to suppress her estrogen levels, which, can throw you into menopause. She's about 45 years old, so this may be hitting her at the same time. And so she presented to me with low libido and then concerns with body image. And she was ready to reengage in partnered sex. So she had a male partner of 15 years. And she identified as queer. She did have a history of sexual concerns and desire discrepancy before her cancer diagnosis, as well as a history of sexual trauma. So again, as I mentioned before, it's extremely important for me to develop a rapport with Curie before I even mention or bring up sensate focus. So what I do is basically do a full psychosexual assessment with her to talk about how did her parents talk about her body, talk about sex, what was puberty like for her. We talked about, how was early adulthood and how was her experience in high school and college, starting to date, first sexual experiences. We talked about history of mental health concerns, and then again, that history of sexual trauma and how is that impacting her currently. For this particular patient, her male partner also had some concerns with this patient's changing body, and basically had a lot of fear around touching her again because he was scared to hurt her. She had a very complicated surgery and reconstruction was very painful. So oftentimes after individuals receive mastectomy, they'll have expanders placed in their breasts before they can get the implants permanently put in surgically, and this can be very painful. So, he had watched her go through this and watched her go through chemotherapy. She also had a lot of concerns because she'd gained a significant amount of weight during chemo and radiation. She was experiencing a lot of fatigue and pain, and so was fairly inactive during this time. And also because she was starting this hormonal therapy, that also led to significant weight gain and holding weight in ways that she did not before. So when she presented to me, she was complaining of, I have zero desire for my partner. I can tell that he is interested in re-engaging in sex. At this point, she had been diagnosed about a year and a half ago and had not had penetrative sex with her partner since that time. And so again, we did a full assessment first, and I worked with her on, addressing some of the history of sexual trauma, which happened when she was in her early 20s. And I oftentimes see that a cancer diagnosis or another physical trauma can bring to light many previous traumas that happened with, especially if they're physical in nature, like a sexual trauma. And so this is certainly not uncommon. Something else that we worked through was that she felt like, going through a cancer diagnosis, especially in light of COVID-19, had left her feeling very isolated, and that her only social support was really her partner, which put a lot of pressure on the relationship. She did identify as queer and had previously had female partners, and felt like she was losing that part of her identity. Again, with being isolated at home, not only due to COVID, but also due to the fact that she was going through a cancer diagnosis and was immunocompromised, and not feeling well for the past 2 years. So, a lot of our work too was finding ways for her to reconnect to her queer identity, and find ways to get plugged into that community, whether virtually or through mentorship programs. So after we had kind of addressed some of these concerns, I brought her partner into session, and we talked about how that they could incorporate the Sensate Focus exercises together. So again, I found it very important for both individuals to be in session with me while I kind of went over what does Sensate Focus look like, why is it beneficial, and why does it work for individuals who've had really any history of trauma, but especially those who've had really significant physical trauma. And this allowed for not only Carrie, but also her partner to ask me questions about, what if we need to modify this exercise, or what if I'm not comfortable with this? And that allows us to be creative together and find workarounds for, basically exercises that work best for them. Something that I'll say also that has really helped me in describing physical trauma to individuals is something from Bessel van der Kolk's Body Keeps the Score. And this is that our bodies do not differentiate between medical trauma and other physical trauma. Our minds cognitively do, of course, and I tell people this a lot, that, I know that you've signed the dotted line for consent for surgery. I know that you've, sat through those consents for chemotherapy and other treatments. So cognitively, you've done that, but our bodies do not realize that. And so something as simple as, going back into a cancer center or going back into a hospital, driving into the parking lot of the hospital can be very triggering, and individuals can have a very strong trauma response. That's certainly not uncommon. And I think this is helpful too for partners to hear that, medical trauma is real, that cancer is certainly traumatic. And of course, it's going to affect someone's ability to, engage in sex. So I brought them both in. We had that initial, basically training session where we went over what does Sensate Focus look like? How can they incorporate that? I had them identify specific times that worked for their schedule. So her partner worked at a factory, a night shift, so they had to get kind of creative with when she was feeling at her best, and basically, when was going to be an optimal time for them to engage in this touching exercise. So once they were able to identify at least 2 to 3 times per week, they would be able to schedule this in. I had them write that on a shared calendar. They did not have anyone else living with them in the home, so they were able to have that calendar on the refrigerator, and it also kind of acted as a reminder for something to look forward to and something fun and sexual that they had on their calendar. And then once they did those exercises, I brought them in to whenever they thought they were ready to progress to that next stage. And that was very helpful because, again, both parties were able to ask questions about what are the limits of this, how do we take the pressure off of penetrative sex? And for them, the goal of sex was not penetration. So Carrie's partner actually had some significant physical concerns that he was dealing with, where he could not achieve an erection due to some medical issues. He was taking some blood pressure medications and had a long history of smoking and substance use that had affected his ability to achieve erections. So we talked about that as well. And again, because Carrie was my primary patient that I was working with, I maintained her as an individual client, but we did talk with her partner about really pursuing his own individual therapy to work on some of these concerns as well. And he was able to do that. And that was very beneficial for him. So again, for Carrie and her partner, penetrative sex was not their goal, but their goal was to increase that physical intimacy with each other and build that libido. So they had this desire, had this time of physical touch that was theirs, and that was very beneficial for them to just increase that intimacy. What we see often is, many people think that, kissing or even hugging or hand holding is going to lead to sex. So if someone is feeling, averse to sex or feeling pressure to have sex, they're going to avoid all forms of touching for those reasons. And so this is a way, especially in the beginning when we take sex totally off the table, that partners can, re-explore that physical touch with each other in a safe way. So Carrie felt comfortable to, hold hands with her partner and kiss him, watch TV on the same couch, because she knew that they had this safe outline of what sex was going to look like for them. And so we were able to kind of work through some of those stages. And all the while I'm working with Carrie on how is she feeling? How is she responding to these phases? How is this for her? How is this for her partner? I also have them, again, not talk immediately after those sessions. I don't want couples to get into the habit of, as soon as their 15 minutes of touch is over, saying, how was that for you? Because again, that adds that pressure back into the situation. So, what I'll have them do is maybe set aside a specific time to talk about the sensate focus interventions with each other on a day that they're not going to be doing sensate focus. So if they've got that scheduled for maybe a Monday and Thursday night, I'll have them talk about that maybe on a Tuesday or Saturday morning when they have some time that's not pressured, no one's moving out the door quickly. And that way they can just, again, touch base on how this is for them, what they like, what they don't like about touch. And then we talk about that again in session. So again, we kind of defined what was the goal for this couple in terms of what sex was going to look like for them. And once they reached that goal in the phases, they were able to incorporate some of the aspects of sensate focus into their sexual repertoire moving forward. So this was very helpful for Carrie to say, hey, I really, I'm feeling, desire for you today. I would like to engage in physical intimacy with you, but I really, I'm not interested in any kind of genital touching today. I would just like for us to kind of stick to a phase one. And so that was helpful for her to have that language about, what she wanted from her partner. This also opens up the conversation for talking about sex with individuals. Many people have never had conversations this explicit about their sexual needs and desires with their partners. So this is also the opportunity for them to explore that with each other. So this was a great use of sensate focus with this couple. It's very beneficial for them. And then, to this day, they're able to incorporate parts of that sensate focus in their sexual repertoire. It's also gotten them in the habit of scheduling, dedicated time with each other, which I think is so important, especially when, schedules are so busy, or for people that have different work shifts. having that dedicated time that they've scheduled to be together is so important. And so this started, a lot of habits that I think were very helpful at maintaining and improving that physical intimacy with each other. So when you're doing this work, again, it's important to have more than just this training to have a full understanding of what sensate focus looks like, and how to utilize that with clients. It's so important, again, to have that good therapeutic relationship with your client before incorporating a somatic exercise like sensate focus into the exercises that you're doing with them. I think it's so important to partner with other professionals that work in this field. So my first bullet point there, refer. So I am constantly referring patients that I work with to pelvic floor physical therapists. And this is a great tool for anyone who's got very significant pelvic pain, or for anyone who's had major physical trauma to the pelvic floor. So again, talking about from a cancer perspective, anyone who has had any kind of pelvic floor radiation, anyone who has had any kind of gynecologic or other surgeries, anyone who's had a radical prostatectomy. There are so many instances where individuals have had really significant trauma to the pelvic floor. And even patients that I see who do not have, direct gynecological or other GU-related cancers, a lot of times systemic chemotherapy can significantly affect nerve endings that also affect the pelvic floor region. So, even if you're working with someone who's maybe had significant neuropathy that may not be directly related to their genitals, there can still be a significant impact on sexual functioning. And pelvic floor physical therapists are a great resource to help with some exercises that these folks can do at home to improve physical pain or functioning. And this extends beyond sexual functioning too. So I know a lot of pelvic floor physical therapists also work with urinary and fecal incontinence. And, of course, this impacts sexual function. So I've got a lot of folks who, are very concerned about urinary leakage or fecal incontinence and being able to engage sexually with a partner. There's a lot of embarrassment around that. So if they feel like they've got some resources to help with control, that can be significant. Urologists are also a great resource. We at the Brown Cancer Center have a urology clinic and a urologist who specializes on pelvic floor reconstruction. So he does a lot of work with pedal implants and artificial sphincters. And this could be very helpful for individuals who have flown through other lines of intervention and want to explore surgical options to restore sexual function. Primary care physicians. So if you've got someone who has very high blood pressure or who is smoking or has substance, issues, incorporating their primary care physician is a great tool because those obviously can affect sexual function and blood flow. And so that education piece, again, that we talked about earlier is so important. And then again, specialty care. So it's important to know your limitations as a therapist or social worker. For instance, I do not treat substance abuse. So if I have someone in session who is very much struggling with substances, and I think it's affecting their sexual function, it's my responsibility to refer them to a specialist who can help address some of those issues. Similarly, if you've got someone with significant physical or sexual trauma and that is not your area, it's important to incorporate a trauma-focused therapist to help with that as well. Some other resources, I know I talked a lot about grief and loss as it relates to sexual function. And so McCarthy has a model called the Good Enough Sex Model. And this was created to address basically changes in sexual functioning for older adults. However, I found it to be very beneficial when working with individuals, regardless of age, who have had significant change in sexual function. And so I think that he does a great job of, bringing in and having basically a strengths-focused way to look at sex and function, and how changing sexuality can be a good thing, and how you can use opportunities to explore new things that you may like, or new ways to find intimacy with your partner. Other books that I recommend frequently to patients are Emily Nagoski's Come As You Are. And this is a book, it is specific to women with vaginas and does a great job of going in depth into how the female body works or how bodies with vaginas work. And basically, incorporates an anatomical approach as well as a psychosocial approach to orgasm, to desire, and to arousal. So she does a great job with her book there. And then Bessel van der Kolk, who I referenced earlier, The Body Keeps the Score. And this is a great text for anyone who has experienced any kind of physical trauma, and can help clients really refocus and identify with their bodies in ways that can help explain some of that trauma that they're experiencing and how they're holding that with them in all instances, not just sexual interactions. And then again, Linda Weiner's book of Sensate Focus and Sex Therapy, the illustrated manual. I love this text. I think it's great for patients to see basically, what can this look like? Oftentimes, it's helpful to have a visual representation, and the charcoal drawings do a great job of, again, incorporating different people, different abilities, different couples or individuals doing the exercises. And so this is a great text as well. So thanks so much for listening to this talk on Sensate Focus and basically the incorporation of sexual health assessment and intervention for patients in chronically ill or oncology settings. Again, I know this is pre-recorded, but if you do have questions, please feel free to email me directly. My email address is laura.jones2@uoflhealth.org, and I'd be happy to follow up. Thanks so much.